Well, thank you. It's great to be here. A hard act to follow after Caitlin earlier today. Um, I am going to take how many steps back? Many, many, many steps back and give you more of the 30,000-foot perspective of health reform from the perspective of what we're doing to try to change financial incentives, realign financial incentives to promote better health at lower costs. Um, our job at the Innovation Center um, is really it's the Innovation Center was started by the Health Reform Bill, by the Affordable Care Act, and we were appropriated $10 billion to do tests. Our tests are tests of new payment models, new ways that we at CMS can leverage different approaches to pay for care, either pay providers, pay health systems, pay hospitals, pay states, with the ultimate goal of improving quality, improving health outcomes, and reducing the total cost of care. There is a really unique opportunity as well at CMMI. There have long been demonstration projects at CMS. One of the things that's very unique about CMMI is that unlike our previous demonstrations, if we're able to demonstrate that any of our models lead to reductions in costs and no change in quality, or improvements in quality and no change in cost, we conduct our evaluation. We need to get it certified by the actuary, and we bring that certified evaluation to the secretary. And if everyone agrees that the results are valid, the process does not have to go through lawmaking. We can, through rulemaking, expand these programs nationally. So we have a really unique opportunity to rapidly implement, test, evaluate, and scale new programs with the goal of improving quality, improving health outcomes, and reducing the total cost of care. So what I'd like to do is briefly walk through with you the programs we've announced to date. The center started just about 2 years ago, so we're still in our infancy, although it doesn't feel like it because we've been really active and we have announced a large agenda of new programs. And as I walk through some of these programs, I'll try to focus a little bit on what it means for childbearing, for childbirth care. But I think the goal here is more to think more broadly about the changing incentives, the changing environment, the changing platform, and what that means for all of us as we strive to improve the quality and reduce the cost of care for the patients that we serve. So the programs that I'll describe are categorized in a couple different ways. A host of them focus on care coordination. This is a central theme of the Affordable Care Act. It was written directly into our statute that we were supposed to emphasize new programs that attempt to improve care coordination for the beneficiaries we serve. And the two categories I'll talk about today are accountable care organizations. We fund the Pioneer ACO models and the Advanced Payment ACO models, as well as the patient-centered medical home models that emphasize and realign incentives for primary care docs. We'll talk a little bit about what we call right care, the improving incentives to optimize outcomes and reduce costs for providers that are delivering acute care services. An example would be bundling hospital services to try to realign incentives for hospitals to deliver higher cost, lower quality care. Higher quality, lower cost care. And I must admit, this is not the first time I've said that. You say it enough times, it's the same as with my kids. About 50% of the time I get their names wrong. We are investing in infrastructure to try to train the next generation of leaders of health reform innovation, health system innovation, health improvement. And we've developed an innovation awards program as well as a healthcare innovation challenge I'll talk a little bit more about that program a little later. And then there's a whole host of activities at the state level that focus on how we can better provide funding, how we can better allocate and align incentives in systems that have often been fragmented in the past, either Medicaid or the dually eligible patients, to try to optimize care coordination and appropriate management of patients. Particularly, there's a huge opportunity here for childbirth. And we'll talk in less than 2 seconds about Strong Start because I think Caitlin more than adequately gave you the scoop on that one. So first, let's talk first about the Pioneer ACO model. This is one that's gotten a huge amount of coverage in the press. The idea is to transition from a shared savings payment model to a population-based payment. So in a broader sense, the idea is that we're going to ask, a health system is going to promise to provide soup to nuts care for the beneficiaries they serve. They are going to be responsible for all of the care that those patients need, and they will be entirely accountable for the total cost of care needed to manage those patients. It means that they have to think very broadly about all the aspects about how patients' care is managed, where there are opportunities to reduce waste, how there are opportunities to improve coordination, where there are opportunities to improve health outcomes and reduce downstream costs. The way in which we reimburse these Pioneer ACOs is we reward them for better quality. There's a number of quality indicators that are specific targets for them that can elicit higher remuneration, or there's a shared savings model. So if these ACOs are able to demonstrate, if these ACOs are able to deliver higher quality, lower cost care for their beneficiaries, if they're able to reduce the total cost of care that they bill Medicare, we'll share in the savings with them. So they now have a financial incentive. They get rewarded for delivering lower cost care. You can imagine that when it comes to perinatal care, when it comes to childbirth, there will be a real incentive, if you're an ACO, to understand the evidence, to understand where results are best, where results are most cost effective, and how to best target and communicate and work with patients to deliver them to the site that best meets their needs, their preferences, and delivers the best outcomes for them at the lowest cost. The advanced payment model is another type of ACO that we've started recently, in which so the Pioneer ACOs are sort of the most advanced health systems that are already well on their way to coordinating care. Advanced payment models are generally rural ACOs. These are ACOs that may not even have a main hospital or all the pieces in place to deliver that soup to nuts care in order for us to help them get rolling. We gave them some upfront capital to help recruit and identify and invest to be able to build the ACO infrastructure to play in the same game that the pioneers play. A really interesting program is the Comprehensive Primary Care Initiative. There is a major commitment to studying how to improve the role of the primary care doctor in the delivery of care to the patients that they serve, by giving them, by empowering them not only with the opportunities to make more decisions, but with the resources to be able to build the infrastructure and transform their practices so that they have the capacity to really care for patients in the way they've always hoped they could. So the way the Comprehensive Primary Care Initiative works is we're working in 7 different marketplaces. In each of those marketplaces, all the commercial insurers came to bat too. So primary care docs have seen a shift in payment from all of the commercial payers for whom they care for patients. And in each setting, we at Medicare and the commercial insurers as well pay the primary care doctor an extra $20 per beneficiary per month up front to improve care coordination for the patient, for our beneficiaries that they serve. The idea is that can help them invest in better HIT, or invest in a nurse practitioner that can help diabetics manage their blood sugars, or hypertensive manage their blood pressure, or hire a pharmacist that can help patients better adhere to their meds or understand the drug side effects. To build that kind of infrastructure amongst a group to deliver a higher quality and more efficient kind of primary care. And on the back end, so that's the front end. The front end is we're giving them more money. On the back end, there's a shared savings model. So we hope that if in that setting where they can follow patients and they don't feel the need to have office visits for every single discussion, because they don't need to necessarily bill for it, on the back end there will be a shared savings model. So if they're able to reduce the total cost of care by handling things via phone or via email or via just better management that don't require that face-to-face visit that used to be required to get billed, they can reduce the total cost of care, and we'll pay them the difference. We'll pay a big chunk of that difference in terms of what was saved. And this, we believe, is a really important way to help fundamentally change the incentives for primary care docs to think differently about how they care for their patients, and frankly, to think differently on a more global scheme about better prevention to keep patients out of the hospital, more thoughtful referrals to try to reduce unnecessary services. The notion that the primary care doc will really have some accountability for the care for the entire patient. And instead of having this very fragmented way in which we deliver primary care, to have a much more holistic, coordinated, sensical way of delivering primary care. Again, this is a setting in which if I were a pregnant woman, I would be, I think, really reassured if my primary care doc participated in a model like this and was thinking early about making sure that I was educated about diet and exercise, and I was hooked into the right perinatal care system early, and I got the support that I need, and I was able to, I think there's real opportunities for primary care docs to play a role in facilitating early and appropriate OBGYN participation. So in terms of acute care, we talked a little bit, I think Caitlin talked a little bit about the partnership for patients. It's a little different than our other models. Our other models are generally focused on a specific new payment for either for doctors or for health systems or for hospitals. The partnership for patients is really a national campaign to try to promote healthier, safer care in hospitals, with very aggressive goals about reducing preventable hospital-acquired conditions, reducing readmissions. And at the time this slide was made, over 3,100 hospitals have signed the pledge to participate. Now it's close to 4,000. So between 75 and 80% of the hospitals in the US are participating in the Partnership for Patients program. The main goal is to improve safety and to try to test an approach in which evidence is shared, and there's learning collaboratives to share new approaches to deliver higher quality, safer care to beneficiaries, which we believe will ultimately lead to cost reduction. When thinking about sort of the approaches that one can apply to improve safety and reduce costs, I'm sure anyone in this room who is close to obstetric care can come up with a number of suggestions about opportunities across the country where delivery patterns, the use of checklists, some sort of quality improvement strategy could lead to better, more efficient, safer, and less costly care. There's a huge emphasis around community-based care transitions, and we invested $500 million in this program in which community-based organizations play a unique role in helping transition patients from the hospital to their home, to the outpatient setting, or to a post-acute setting, because that's a very difficult time for many patients, particularly in Medicare. Frankly, being a father, the first time I drove out of the hospital and tried to figure out how to put the car seat in and drove down the street at 2 miles an hour and didn't understand why everyone wasn't stopping for me. I would imagine that there is a unique opportunity here as well. I'm not sure the extent to which our community-based care transitions program is focusing on this population in particular, but this is an area where there's a great deal of misunderstanding. Everyone says the joke that I didn't get the handbook, I didn't get the rule book, and there's unquestionably a unique opportunity here to help new parents at that time of transition to better maintain the safety, improve feeding, improve sleeping, improve the parents' sleeping, and encourage better care. Another unique opportunity, one of our biggest models is the bundled payments for care improvement. We, historically, the way we've paid hospitals for at least the last 20 years is we bundle the cost of the hospital stay, but the providers bill us as much as they can. So we have a DRG for the hospital portion of a visit, and it's in providers' best interest to get lots of referrals and try to bill CMS as much as possible. The idea here is to say, well, let's come up with a bundle for the entire care episode, and not just the inpatient episode. Let's see what happens if you do a bundle for the care episode and post-acute care. And let's see what happens if you pay for it, if you adjust it retrospectively versus come up with prospective bids for prospective costs for these types of episodes. And the goal is to make sure that hospitals have the right incentives. Incentives, A, to deliver, not to bill us as much as they can, but to bill us for what's appropriate. And if they're able to reduce costs, there's a gain sharing opportunity, so they get to keep some of the money. We also want to reward them for higher quality. The way we reward them for higher quality is we hold them accountable. If patients get readmitted over the next 30, 60, 90 days, it comes out of their hide. So there's a whole new level of accountability for them to make sure that when those patients are sent home, they're sent home with a good plan, to follow up with their primary care doc, to follow up with their OB if it's if there's childbirth, and to make sure that their patients are getting their medications when they leave the hospital. Currently, there isn't a bundle explicitly around childbirth, but this is a brand new program. It was announced very, very recently, and we should, it's a program that I'm sure will evolve and change and improve in the years to come. How much time do I have? Is that right? Okay. So we're doing a lot in states where there's a whole host of efforts around coordinating care for dually eligible patients, and there are a couple different models. The rationale is that historically there were Medicare, so dually eligible patients have some of their benefits paid for by Medicare, some by Medicaid. That created a whole host of perverse incentives that led to unnecessarily high spending. And the goal is to try to coordinate those sources of payments to come from a single pot and to have a thoughtful, objective way of delivering care to these patients. This is a population that for sure better management of childbirth, of perinatal care has to be a priority. And similarly, state innovation models are focused largely on Medicaid. As everyone in this room knows, a huge proportion or a huge amount of spending in Medicaid is around childbirth and perinatal care. And as states try to innovate and transform the models that they use to pay for care within their states, it would be certainly short-sighted for them not to include childbirth as an important target. I'm not going to talk about Strong Start because I think you've been well immersed. And this is the last slide. I just wanted to give you a sense of So what we're trying to do at the Innovation Center is to kind of hit the whole continuum of care, whether it's the primary care doctor, the hospital, the health system, the state. We're trying to realign incentives to reward providers for delivering higher quality, lower cost care, and with a real focus on improving health outcomes. And frankly, there are very few in which childbirth isn't part of the game. You know, there's a whole host of issues that all of these folks are going to have to think about, and they're going to have to think about what are the highest cost issues and the greatest places to reduce waste. But the more that advocates and folks who spend their time thinking about improvement in this area, in this arena, can bring meaningful evidence about strategies to improve quality, reduce cost, improve patient satisfaction. These are organizations that'll be all ears, and we'll be really interested to hear from you. And I hope that there's great opportunities for collaboration in the years to come. Thanks.
Thank you for a very stimulating talk. There's clearly a lot happening in the payment arena. And as we look to having higher value in our healthcare system, it's extremely important to understand one part of the value equation, which is what are the costs of care in different settings. And it's absolutely critical to understand that in order to have the discussions about value and in order to be able to inform payment innovation approaches. So it's my great pleasure to introduce to you our second speaker, who's Dr. Lori Cawthon, and she is from the Washington State Department of Health and Social Services. And she has done some really tremendous work on the cost of alternative care settings, and I'm really looking forward to hearing her talk, as I'm sure you will be, as she tells us what the numbers are for these various settings.